This video will be essentially a continuation of the previous one. We know that in the previous video we saw the core principles of hypothyroidism and the investigatory part. In this particular section we'll be discussing in detail about the clinical features and the management of hypothyroidism. I generally divide hypothyroidism initially into two phases. One is called a congenital hypothyroidism, second is the adult hypothyroidism. Even though this congenital hypothyroidism is not so uncommon or not so common, but it falls in between, but still it is one of the very important preventable cause of mental retardation in the country and in the world as well. So that's why I want to first finish off that, then we'll move on to the adult hypothyroidism and what are the causes. Congenital hypothyroidism you can divide and classify into primary congenital hypothyroidism, where the problem definitively will be in the thyroid gland, then only you can call it as primary, or it could be a central congenital hypothyroidism, where the problem will be usually in the pituitary or the hypothalamus, which we can further differentiate into secondary or tertiary according to your physiology textbooks, but I need only the term central congenital hypothyroidism, that's it. So which is more common? Obviously, as you expect, the primary congenital hypothyroidism is going to be the most common, and the primary thyroid issues itself you can divide into two aspects. One is structural thyroid problem, which generally tends to be sporadic and not inherited. And second one, functional thyroid issue. Like many conditions are coming under functional thyroid issues, let us see, but it is less common. Structural thyroid issues, they are sporadic already, but again they are going to be the most common compared to functional. Almost 98% of the congenital hypothyroidism will be because of structural issues only. And central congenital, very, very rare, less than 1%. Let me tell you separately at the end. So the structural thyroid issues may be due to two reasons. One, it could be a thyroid dysgenesis, otherwise called as a thyroid hemiagenesis, or otherwise thyroid hypoplasia. So it's a thyroid dysgenesis. By far, this is the most common cause of congenital hypothyroidism. Or it could be thyroid agenesis, complete absent thyroid gland, or thyroid aplasia, which is even more severe form, but unfortunately it is very rare. Second, you get ectopic glands also, where the thyroid gland in the ectopic location, commonly in the lingual side, that's what we studied in embryology. So thyroid gland at ectopic location may not function properly, that's the idea. Functional problems, it could be dyshormonogenesis, where there could be some deficiency of hormone synthesis mechanism. One of the best examples for dyshormonogenesis is Pendred syndrome, where there is a deficiency of pendrin protein. So usually results in sensorineural, hearing loss, and hypothyroidism, right? Or it could be iodine deficiency. So I can write Pendred syndrome, or probably second example could be iodine deficiency. But please do remember, in the modern era, iodine deficiency does not cause cretinism except in certain endemic areas like Congo, New Guinea. Usually iodine deficiency results in only a transient hypothyroidism in the neonate. It doesn't result in cretinism, but only in endemic countries this iodine deficiency can result in cretinism, formation of these cretins. Otherwise, it's only a transient hypothyroidism. Second, it could be very rare causes like MCT8 deficiency. So this is an X-linked disorder, MCT8, and majority of the dyshormonogenesis will be familial and inherited, and many of them will be autosomal recessive as well, like Pendred syndrome. And MCT8 deficiency, on the other hand, is X-linked, very, very rare. The syndrome that is resulting due to this MCT8 deficiency is also referred to as Allen-Hendon and Dudley syndrome. Allen-Hendon-Dudley syndrome, right? So recall the function of MCT8. So where MCT8 is very important. So if you take, this is a thyroid follicular cell, and you have MCT8 transporter. This MCT8 transporter is crucial for release of the stored thyroid hormones from inside the cell to outside the cell. So if this is deficient, you will result in one of the very important clinical feature, that is severe MR. And the TFT rearrangement will not be that bad. You will have a low T3 and T4 all right, but you will have only a mild increased or even a normal TSH, which means you don't get much of TSH abnormality. Why severe MR but not much TFT defects? This is because this MCT8 transporter is very, very important, not only for pushing the thyroid hormones out of the cell from the thyroid follicular cell, but also it is important to push the thyroid hormones into the neurons in the brain. especially T3. So that might result in severe MR because T3 is very, very important for mental growth of the child in the uterus. So if that is not there, then it's really difficult. And treatment-wise, you have to give some thyroid hormones that is not utilized by this MCT8. It's an artificial thyroid hormone or a different type of non-classical thyroid hormone like DITPA or a TRIAC. DITPA is diiodothyropropionic acid and TRIAC is triiodothyroacetate. So this is what we call TRIAC. So these are something that's used. Both are orphan drugs, can be utilized for this MCT8 deficiency people. Third, there are a lot of other rare causes like TSH receptor mutation. Because of that, the TSH receptor may not work properly, or it could be a sodium iodide transporter deficiency. So very, very rare causes. So overall, this functional problems itself is very rare nowadays. It's usually structural problems only. Clear? On the other hand, central congenital hypothyroidism is even more rare, but there are certain features that will tell you the patient might be having a central congenital hypothyroidism like cleft lip, especially if it's a midline cleft lip, or a patient may have a micropenis, a lot of other issues. And one of the very important causes is septo-optic dysplasia, where we studied that the patient will be having some midline issues like corpus callosal agenesis, absent septum pellucidum. I bet you we have studied already in the pituitary section, right? Septo-optic dysplasia can also result in congenital central hypothyroidism. Fine. But remember, whenever you have central congenital hypothyroidism, always rule out other panhypopituitarism. Other enzymes may also be deficient here, not only thyroid hormone. There could be deficiency of ACTH and cortisol. There could be deficiency of growth hormone. So replacement of all other hormones, if they are deficient, is also vital, because otherwise child may not attain a good height if the growth hormone is deficient. Or the child may go for crisis if there is a cortisol deficiency, Addisonian crisis or adrenal crisis. So be very careful about all those things to find out other associated hormone deficiencies whenever you have a central congenital hypothyroidism. Clear? So now we know the causes. So what are the clinical features? So clinical features of any congenital hypothyroidism will be this. Like they'll have a certain set of features, especially in the postpartum period. But remember, almost 95% of the children or infants will be asymptomatic at birth. So this is a very important data. Why 95% of the children will be asymptomatic at birth? That is because of the maternal thyroxine that is circulating in the blood of the infant and the neonate. So they won't be symptomatic. Over time only they will develop symptoms. So what are the symptoms they will develop over time? The first one, umbilical hernia. Very, very, very important. Umbilical hernia. This is a time-tested point. Every exam has this point. If they want to give a congenital hypothyroidism, you can see the umbilical hernia in this child, prototypical child, and second one, hypotonia. Yes, very, very important again. Here you can see the child's limbs. Like it is flaccid. Actually, child will be like this. It's going off. Like it's hypotonic child, and you can see a protuberant abdomen. Right? It's a protruding umbilicus with a protuberant abdomen. Protruding abdomen. Right? And the child may have this. This is macroglossia, right? Very, very important. Protruding tongue because of macroglossia. And you can see what are the facial features of the child. Child is having a very coarse facies, isn't it? So coarse facies. And child may have reduced activity and poor crying, poor feeding, and adipsia. Adipsia in the sense a child doesn't drink the breast milk properly. Adipsia, poor feeding, and hoarse cry, different voice, and delayed closure of fontanelles. Delayed closure of fontanelles. Apart from that, in the neonatal period itself, many of the children will experience bradycardia. They might experience hypothermia, and they can also have a prolonged neonatal jaundice. This is a very important point. There are many causes of prolonged neonatal jaundice, but like congenital hypothyroidism is one important cause. The examiner will surely give this if he wants you to diagnose a congenital hypothyroidism, prolonged neonatal jaundice. So usually we can remember this by 6 P's. One is a pot belly, protruding belly. So that's a pot belly. Second one is puffy face, obviously, because it's like a mixed edema, so they will have a puffy face. Third one, they have a protruding umbilicus. That is because of umbilical hernia. Protruding tongue. So that is because of macroglosia, and they will have poor brain development, number 5. Obviously, we know that. And finally, they will be pale. So these are the 6 P's that you have to know: pot belly, then protruding umbilicus, then pale, puffy face, and poor brain development, and protruding tongue. That's because of macroglosia. So there are 6 P's that you can remember for remembering the congenital hypothyroidism, right? So what about this? We have discussed about congenital hypothyroidism, all right, but what is this? This is an extreme form of congenital hypothyroidism due to iodine deficiency disorder. That is due to extreme iodine deficiency, and the resultant formation of this cretinism. This is extreme stage. Like this is usually not the case in the current world. It doesn't happen. Still, it might happen in very, very underdeveloped countries like Congo or New Guinea sometimes. But, like in India, again, it's currently very, very rare. It's because we use a good amount of iodine. And the government has done a beautiful job in supplementing iodine to the people by implementing strict rules on iodized salts. But anyway, this is still endemic in certain rare areas, right? So what do you mean by this? This is cretinism. It's an iodine deficiency disorder. It's little different from what you see a congenital hypothyroidism. So this is due to deficiency of the maternal iodine itself. It's not only the child is deficient of iodine, it starts from the maternal. The mother itself may have a big goiter and she gets pregnant, and mother itself is not having sufficient iodine, and the child the child in the uterus suffers from severe iodine deficiency and severe thyroxine deficiency. That will result in cretinism. It is an iodine deficiency disorder. Please box that. And there are 2 types of cretinism basically. Whatever may be the type of cretinism, they will be having a severe mental retardation. The mental defect will be very severe, whatever may be the type of cretinism. But there are 2 types that are identified. One is neurogenic cretinism, and second one is myxedematous cretinism. Myxedematous cretinism. So neurogenic forms usually have a goiter. Neurogenic forms usually have a goiter, whereas myxedematous forms will not have a goiter. And neurogenic forms, usually they'll be deaf and mute, and they'll have a characteristic stance, and they'll have cerebral diplegia and spasticity. You can see by the image over here, they have goiter. At the same time, you can see them, they have a characteristic stance. How they stand, you can see. And they will be spastic with cerebral diplegia. At the same time, they'll be deaf and mute. They cannot hear and they cannot talk. But all these things will not be seen in myxedematous forms. So what you will see in myxedematous forms, most prominent things will be short stature. At the same time, you will have, which is not a usual problem in neurogenic cretinism, but apart from that short stature, they will have a delayed puberty. They will have myxedema, which means they will be puffy. You can see those children. And you can see this is a normal child on the right side for comparison. And you can see the height is less. At the same time, you can see some bone problems like here, genu valgum. And they are a little bit puffy. That is myxedematous. And you can see the face, which is puffy myxedematous. And they'll have a delayed puberty. And they also might be having other problems like pseudo-hypertrophy of the muscles. With severe myopathy. And they'll have a prominent abdomen and hypoplastic mandible. So these are some of the features of myxedematous cretinism, right? But what will be the TFT? TFT is interesting here. So since they do not have a goiter, remember, whenever they have a goiter, so why they do develop a goiter is because to make the thyroid hormones in excess amounts. Not excess in the sense you should not mistake here. Excess means already there is deficiency, to create a little extra thyroid hormones and to keep the thyroid function test in the euthyroid range. So that's why they develop the goiter. So most of the patients with the goiter, mark it as a rule, they usually have a euthyroid status. Even in an iodine deficiency disorder in adult, if they have a goiter, very likely the thyroid function test will be normal, which means they will be euthyroid. The reason why they develop the goiter is to keep the TFT in the normal range. That's why the goiter, that's how the goiter functions. So these patients do not have the goiter. So that's the reason they usually tend to have undetectable thyroid hormones, because without a goiter they cannot produce that sufficient amount of thyroid hormones, and they will have extreme elevations of TSH. And trust me, this extreme elevations of the TSH is the reason for this mixed edema in the first place. There are a lot of reasons, because in Graves' disease, why you get mixed edema? I mean, that's called a peritibial mixed edema. And in hypothyroidism, you get a mixed edema. So both have similar pathophysiology, both share a similar pathophysiology. That's because of excess TSH. That's the reason. Because this TSH sometimes may stimulate the TSH receptor in the fibroblasts, which secrete glycosaminoglycans, which may draw water and they may cause edema in the local area. That's the reason. Here, there is a goiter in neurogenic cretinism, which means they will be having usually euthyroid picture. They won't be having abnormal TFTs. Many of these children will have euthyroid picture. But the damage has been already done in the childhood itself, in the uterine life itself. So that's why they are severely affected in the form of severe MRN, all this deaf mutism and all. So this is a iodine deficiency disorder, and there could be some questions on cretinism in the exams also. But right now, it's very rare in the current days. But still, please do remember this facts about cretinism. Now we'll move on and try to understand and start evaluating how to screen a newborn congenital hypothyroidism and how will you treat them. So that's very important. So we are moving on to a new area called newborn screening. How will you screen the newborn? So majority of the inborn errors of metabolism in US is screened with a heel prick test. In India, even though a lot of inborn errors of metabolism go unscreened, but still we do this heel prick blood, and we take this finger prick test or heel prick test and we send it to a sample in a paper blot, and this heel prick blood will be evaluated for TSH. TSH is a very robust and we have a very good evidence to find out. So why only TSH? Why we are not using T4 here? Because, like whenever you use the word screening, so whenever you use the word screening, which means it should be cost effective, because you are applying for the entire population. You are applying for the entire population and it must be cost effective for sure. There is no doubt about that. That is the reason why when you are using for a mass screening, you prefer only one test, single test. You don't do a combination of tests, even though they are better. If you use a T4, it's really better, but TSH is for cost effectiveness. There are some T4 based algorithms also, but we don't really use TSH based algorithms are, like what we use in our country at least. So what should be the values of TSH and when you should do the TSH, when you should do the screening? Usually the first screen is done after 1 to 2 days of birth. 1 to 2 days of birth, you do the first TSH. This is the point where you do the newborn screening. But you should be aware of the fact that this point, the TSH will be very high. So because of the physiology which I have told you in the last video. So you have to know what is the cutoff you have to use. So within 24 hours, if it's more than 60, you can suspect. If it's in the range of 24 to 72 hours, if it is more than 30, you can suspect. Or if the child is more than 72 hours of age, and if TSH is more than 20, you can suspect. This is screening and it's a spot test. You suspect, you don't confirm. So with these values, you can suspect a congenital hypothyroidism. But please remember, since majority of the algorithms and guidelines say that you have to do TSH after 1 to 2 days, which means TSH will be done on the 2nd or the 3rd day after birth, which means this value becomes really, really important. If it's more than 30, in the 2nd or 3rd day, there is a strong suspicion of congenital hypothyroidism. So once the values are more than 30, once the reports are come, you have to do some confirmatory tests, because we have done only the screening test, but we have to do the confirmatory test. What is the confirmatory test that we are planning to do? So we have to do a T4 and a TSH both now. You have to repeat them. When you have to repeat? At 1 week. Usually, ideally, we have to repeat by 1 week. That's the correct time where you have to repeat. Okay. I told you at 1 week of age, even the TSH of more than 10 is highly significant, which means by 1 week, the TSH usually reaches to less than 10, usually. But even if it is more than 10, this is definitely very, very significant. Clear? So based on this, you can extrapolate the results. So where I can write as a primary hypothyroidism. How will you tell it's a primary? Obviously, if it's a low T4 and if it's a high TSH, I call it as primary. This T4, what you find, it could be a free T4 or it could be a total T4, or you can use a resin uptake test, whatever. So I don't care. So, but we see the T4, that's it. Second one, we have a secondary or a central congenital hypothyroidism, where you know the value, the T4 will be low for sure. There will be either increased or a normal TSH. Clear? So this is central hypothyroidism. Or you can have a subclinical hypothyroidism. So what do you mean by subclinical hypothyroidism? You will have a normal T4 but a elevated TSH more than 10. This is subclinical hypothyroidism. Or the child can be completely normal, where you'll have a normal T4 with a normal TSH. Fine, all right. Now, whenever you make a diagnosis of a primary congenital hypothyroidism, now there is a sure that it's a primary congenital hypothyroidism. Obviously, you have to treat them. I'm not telling you should not treat, but what will be the etiological screen? So you have to search for the etiology. So what is the basic reason why they develop this congenital primary hypothyroidism? So etiological screen, you have to do two testing. One is the radioactive iodine uptake, along with we'll do ultrasound of the thyroid. Radioactive iodine uptake can be divided into those children who have a positive radioactive iodine uptake and no radioactive iodine uptake at all. If you have a positive radioactive iodine uptake, you have to see whether the uptake is in the normal area where you see the thyroid. So where you will diagnose probably dishormonogenesis, like your Pendred syndrome, or probably it could be a iodine deficiency. So we are going to suspect dishormonogenesis. That's the issue. Suppose if you see in the ectopic area, where thyroid usually should not be there. So obviously we are going to diagnose ectopic thyroid tissue. That's it. So when the radioactive iodine uptake is negative, when radioactive iodine uptake is not there at all, then do the ultrasound of the thyroid. So see the ultrasound thyroid results. Thyroid can be visualized or thyroid may not be visualized at all. If thyroid is not visualized or poorly visualized, usually it goes towards a structural problem, like dysgenesis or agenesis. That's what the idea is. Thyroid is visualized normally, but the uptake is not there. What could be the possibility? Rarer possibilities, like it could be a sodium iodide transporter deficiency, or it could be TSH receptor mutation. So very rare causes. So even though I have classified the causes, but most importantly, what you have to know is the next step. To find out the etiology, you need radioactive iodine uptake and ultrasound of the thyroid. Very, very important. Whenever you have a central congenital hypothyroidism, again you have to work up something like an MRI. Definitely that is needed. Pituitary MRI is a must, and you have to rule out other hormone deficiencies. Rule out other hormone deficiencies, especially cortisol and ACTH deficiency. This is a must. You have to rule out. Clear? Because it could be a pan-hypopituitarism rather than just a hypothyroidism. So rule out. So both these have to be treated. There is no doubt about that. Without a doubt, all these patients with primary or central congenital hypothyroidism has to be treated. And the usual treatment dose is 10 to 15 microgram per kilogram per day. So this is a very important point, because you know the adult dose. Adult dose is a meager 1.6 microgram per kilogram per day, but in children it's very high. As a rule of thumb, for a term infant, usually we prefer giving 50 micrograms per day, and a preterm infant we give 37.5 micrograms per day. But still, it's important that you calculate the dose according to the weight, but it's very high compared to the adults. Here it is 10 to 15 microgram per kilogram per day. Okay. What about subclinical hypothyroidism? Here, 1 week TSH is more than 10 and the T4 is normal. So what are you going to do here? You have to see what is the TSH value. See what is the TSH value, whether it is more than 20 or whether it is in range of 6 to 20. Clear? So if it is more than 20, then definitely you have to start the treatment. There is no doubt about that. You have to surely start the treatment because such a high TSH is not a joke. You have to start. And 6 to 20 means you can safely observe these children because you have just done a 1 week TSH. Some children might normalize the TSH a little later. So just observe these children for a while and monitor and repeat the TSH at 4 weeks. You have to repeat the TSH at 4 weeks. Remember, at 4 to 6 weeks, the TSH should have normalized completely. At around 6, less than 6 in fact. So if it is more than 6 to 10, some people will keep a cutoff of 6, some people will keep a cutoff of 10. Anyway, if it's more than 6 to 10, I can tell that this patient again needs treatment. There is no doubt about that, which means even at 4 weeks, they have not yet normalized the TSH, which is clearly abnormal. If it is in the range of less than 6 to 10, which means they have normalized, means you can give no treatment and you can leave the patient free. This is how you manage a subclinical congenital hypothyroidism. Clear? So this evaluation is really important, especially this evaluation of how to do, what is the TSH values, at what time, what should be the TSH value. So 5 cutoffs you have to know. Within 24 hours, more than 60, 24 to 72 hours of age, more than 30, and more than 72 hours, more than 20 at first week, more than 20, more than 10, and at 4 weeks, it should be normal. It should be less than 6, ideally, at 4th week. So that's the idea. So this is what, this is how we evaluate a subclinical, a congenital hypothyroidism. So very important points. So I think now we have successfully completed the congenital hypothyroidism. Let us move on to adult hypothyroidism. Adult hypothyroidism may be due to a variety of causes, but I generally divide into goitrous type. So where these disorders form a goiter, and second one is non-goitrous variety, where they usually do not form a goiter. Goitrous obviously is supposed to be the most common, and the number one cause is always thyroiditis. Thyroiditis can be autoimmune or non-autoimmune, but very importantly, this autoimmune thyroiditis like Hashimoto's. Yes, we have a separate session on thyroiditis, so no need to worry, but you have to know this. So this is the most common cause of hypothyroidism in the United States, in the West, even in India. Most common cause of hypothyroidism. Thyroiditis, we all know they form a triple response with respect to the thyroid function. So this is the time in the x-axis and the thyroid hormones in the y-axis. We can put a euthyroid range. So let us assume this limit forms the euthyroid range. So what happens is initially the patient will be in the euthyroid range. They get a thyroiditis attack. They go for initial thyroid toxic phase. This is very important. Initial hyperthyroid phase, that is because of not excessive synthesis of the hormone, that is because of destruction of the gland and release of the stored hormones. That's the reason why they go for hyperthyroid phase and thyrotoxic phase initially, which always tends to be temporary and transient. It will never be permanent. And then they come to a hypothyroid phase that can exist for months together. This hypothyroid phase can be temporary or they can be permanent as well, depending on the initial injury, depending on the host factors, depending on whether ongoing inflammation is there or not, presence of antibodies, a lot of things predict whether they go for permanent hypothyroidism or they recover and they reach a euthyroid state, right? They might or they may not, depends. This is the euthyroid range. So this is a classic three-phase response for thyroiditis, and very common thyroiditis in the world is Hashimoto's thyroiditis only. That's why we are going to discuss in detail about Hashimoto in the future. Fine. And we have a lot of other detail like radioactive iodine uptake will be low during the thyroiditis phase, and so many points are there. So let us not worry about all those things and let us move on to the next cause, that is nutritional iron deficiency. Remember, thyroiditis does produce a small goiter. Yes, they do have a small diffuse goiter. They do have. So don't worry about the thyroiditis is not a goiterous cause. It's a goiterous cause only. And what about nutrition, iron deficiency? Before going into the actual clinical features of iron deficiency, let me tell some of the nutritional facts about iron. So first is the RDI, recommended dietary intake. There are two bodies that give different values a little bit. One is WHO, second is US Task Force. WHO is what we have to follow for the exams, and which clearly tells any adult patient. By definition, according to iodine deficiency, more than 11 years is adult for WHO. So they should receive 150 micrograms of iodine per day. So this is the recommended dietary intake as per WHO. Any non-pregnant adult, which means for pregnant adults and lactating mothers, the need will be very high, approximately 250 micrograms per day. On the other hand, infants will be needing approximately 110 to 130 microgram per day, and children in the range of 1 to 11 years. They are the only people that are left now. So they need approximately 90 to 120 microgram per day. Clear? So US Task Force tells little different for pregnant and children, but adults is the same. It is 150 microgram per day, which means adults, every guideline is almost same, that is 150 microgram per day. So this could be a very, very important question. No controversy at all. Of which 80%, 120 microgram is utilized by the thyroid gland alone. Fine. So pregnant, it is approximately 200 to 220 microgram per day. Children wise, they give a different age cutoff. Like for example, so children will be different. So I'm putting a box here. So if the child is an infant or up to 6 years of age, you need 90 micrograms per day. And in the range of 6 to 12 years of age, they need 120 microgram per day. So this is the US Task Force guidelines, but no need to remember. So you need to remember only the WHO. Most importantly, the RDI for a non-pregnant adult, and very importantly, pregnant adult. Because they like this pregnancy in India, especially Indian exam. So you have to know that pregnant value at least. How the government of India and United States, like developed countries, have prevented this iodine deficiency? Simple method, by fortifying the salt. So this is called fortified salt, or otherwise referred to as iodized salt. So where they added iodine, and the recommendations for iodine by government of India is 150 parts per million. So which means 150 parts of iodine in 1 million parts of salt is the recommendation right now by Indian government. Second, the US Task Force recommends 70 microgram of iodine per gram of salt. But obviously Indian recommendation is what you have to know. By fortifying the salt, you can prevent iodine deficiency to a great extent. Right now in India, 91% of the homes, as per the 2013 data, is receiving iodized salt. So which is a very good thing. Clear? So we should soon reach 100%, obviously. And what is a dietary marker? Like how can you find out whether the patient is taking sufficient iodine or not? This is important for epidemiological purposes when you are screening a community. So you can use this urinary iodine. So as a screening marker or as an epidemiological information to know whether they're taking sufficient iodine in the community or not. So if the iodine is more than 449, so urinary iodine means we are talking about micrograms per liter. So if it is more than 299. Micrograms per liter, we are going to see in micrograms per liter. If it's more than 299, it's possible excess. And if it is in the range of 200 to 299, it's supposed to be adequate. If it is in the range of 100 to 199, it is supposed to be optimal. If it is in the range of 50 to 99 micrograms per liter, it is supposed to be mild deficiency. If it is in the range of 20 to 49 micrograms per liter, it is moderate deficiency. And if it is less than 20 micrograms per liter, it is supposed to be severe deficiency of iodine. Clear? So this also corresponds to an extent to the dietary intake also. So this urinary iodine to an extent corresponds to the dietary intake. If it is more than 299, it corresponds to more than 449 micrograms per day of iodine intake. 200 to 299 corresponds to approximately 300 to 449 micrograms per day of iodine intake. 100 to 199 corresponds to 150 to 299 microgram per day of iodine intake, and urinary value of 50 to 99 corresponds to approximately 75 to 149 micrograms per day of iodine intake, and 20 to 49 corresponds to 30 to 74 micrograms per day of iodine intake, and less than 20 corresponds to less than 30 microgram of iodine intake. So you can to an extent correlate with the iodine intake also, clear? But this mild, moderate and severe deficiency is important for your exams, especially in terms of urinary iodine. Remaining you can forget, but these three values at least try to remember, that 50 to 99, 20 to 49 and less than 20. Urinary iodine correlates with mild, moderate and severe iodine deficiency. Fine. So what are the clinical features? How they present? So there are a group of disorders called iodine deficiency disorders. How they present in adults. In children, I told you, cretinism, very important. That's endemic cretinism. We discussed already. What about adults? Adults, they come with goiter. Endemic goiter. They typically come with goiter. And this goiter can be of two types. One is a diffuse goiter. That is what you see in early stages. That's a smooth diffuse goiter. But in late stages, they will go for nodular goiter or a multinodular goiter in late stages. That's what happens. But surprisingly, if you take the thyroid function test in a patient with iodine deficiency, most common TFT that you will see is euthyroid, which means the patient will not be hypothyroid. You can understand that is the reason why they develop goiter. I told you this fact already in the cretinism itself. The reason for developing the goiter is to maintain the euthyroid state. So big goiters, usually they are associated with euthyroid state. Very rarely they can be hypothyroid, but rare. We don't generally encounter. Fine. So this nodular goiter has a different fate. For example, this nodular goiter may remain as a nodular goiter, but if it's a long-standing nodular goiter, still you have not treated sufficiently. So what might happen is there can be continuous stimulation for the TSH, even though TSH is not raised typically in these patients, but because of the iodine deficiency, there is an urge for the TSH to stimulate the gland continuously to take up that whatever iodine is there in the body. Because I told you the most powerful stimulator of sodium iodide transport and iodine uptake by the gland is TSH. So since there is iodine deficiency, the TSH will be keeping on stimulating different parts of the gland, and in certain areas, they might go for mutations of the TSH receptor. Let us see that. So suppose this is the gland and you have different nodules in different areas, and a lot of areas, like they have this TSH receptors, isn't it? Because of continuous excess stimulation of TSH on the TSH receptor, because they need to take up iodine, they are in the necessity now. So certain TSH receptors, because of continuous stimulation on the TSH, they may go for gain of function mutations. That's in accordance with the Darwin's theory, isn't it? When you stimulate something continuously, they grow. When you don't use or don't stimulate at all for a long time, they go for atrophy. This is something very simple to understand. So they are keeping on stimulating the TSH to take up the iodine, whatever iodine is left, to take up. And finally, they go up for this gain of function mutations, which means this gain of function mutations of the TSH receptor indicates they become autonomous. They become autonomous, which means now they don't respond to the TSH at all. In the sense, whether TSH is there or not doesn't matter. This receptor will always be stimulated, will always be active. They take up iodine no matter what, and they keep on regurgitating the thyroid hormones. So ultimately, when the iodine is replaced and the patient gets a good iodine diet, these autonomous functioning nodules, initially they are a little bit protected to maintain the euthyroid phase, but later on, if the iodine is sufficient and the pathology has been cleared, means these autonomous nodules may go for toxic state, which means they can start producing excessive thyroid hormones by taking up more and more iodine. So if it's a single nodule that's producing this excessive thyroid hormone, it's called a solitary toxic adenoma. Or if it's a multiple nodules that's producing excessive thyroid hormones causing hyperthyroidism and thyrotoxic, that's called a toxic MNG, otherwise referred to as a Plummer's disease. Clear? So usually they will go for a toxic multinodular goiter only. This is the usual fate. Solitary toxic adenoma is very rare in the setting of iodine deficiency. Usually a follicular adenoma getting a TSH receptor mutation. Follicular adenoma is something, a tumor, we saw that in the thyroid malignancy. A follicular adenoma, getting a gain of function mutation of TSH receptor, going for a solitary toxic adenoma is quite common. But iron deficiency causing nodular goiter usually go towards a toxic MNG only. So clear? So treatment of toxic MNG is something similar to that of Graves' disease. We can treat with antithyroid drugs, or you can treat with thyroidectomy, or you can treat with radioactive iodine also. All different options are there. Fine. So this is the fate, and this is a clinical picture that you're going to get in a goiter with an iron deficiency. So we have told a little bit in detail about iron deficiency. Now we are going on to the third cause. What is the third cause of goitrous hypothyroidism? First one, thyroiditis. Second one, iron deficiency. Third one is drugs. There are two drugs that are very important. One is lithium and second one is amiodarone. Very important. Lithium and amiodarone. In this, you know the importance of amiodarone. Amiodarone can cause hypothyroidism. Amiodarone can cause hyperthyroidism. Amiodarone can cause goitrous hypothyroidism. Amiodarone can cause non-goitrous hypothyroidism. Amiodarone can cause thyroiditis. Amiodarone is very toxic to the thyroid gland. That's it. The name itself tells amidarone. Am containing a lot of iodine. Amiodarone contains 37% iodine by weight. That is the reason for all these problems. They can cause hypothyroidism by Ulcheckov effect, or they can cause hyperthyroidism by Jod-Bestev effect, or they can cause thyroiditis itself. We'll discuss amyloid-induced thyroiditis under thyroid dissection separately. What are the causes of non-goitrous hypothyroidism? Non-goitrous, very simple causes. Surgery, surgical removal of the gland, no brainer, easy one. Then radioactive iodine ablation, understandable. Radiotherapy to the neck, understandable as well. Definitely, it's like a radioactive iodine ablation only. Drugs like amiodarone. Amiodarone, I told you, they can cause anything and everything. Clear? Non-goitrous form of hypothyroidism. Clear? We are talking about the primary forms. In adult, this goitrous and non-goitrous, we talked about only primary forms. Secondary forms and tertiary forms, I intentionally did not describe because it's very, very rare. So whenever you get a central hypothyroidism in an adult, usually it will be associated with panhypopituitarism. That's all. Some other cause of hypothyroidism will be there. Cause of hypopituitarism we have discussed already in detail in the pituitary basic video itself. That itself may result in a secondary hypopituitarism or a central hypothyroidism. So no need to worry about that much. So we have to know about some other causes. Life is all about knowing these extras. So please know about this other causes. That's what I wanted to emphasize. What are the other causes? Number one, drugs like interferon, very important. Second, tyrosine kinase inhibitors. How they cause, we don't know. Currently, we don't know. Probably this tyrosine kinase inhibitors can cause hypothyroidism by causing thyroiditis, but only speculation. We don't know the exact reason. Usually this tyrosine kinase inhibitors causing hypothyroidism is common in women, especially if they are taking the tyrosine kinase inhibitors for more than 6 months. And the incidence of hypothyroidism in these women who are taking for more than 6 months of tyrosine kinase inhibitors is almost 40%. Humongous. Almost 1 in 2 will develop this hypothyroidism because of tyrosine kinase inhibitors. Very, very important. These are institute exam material. So definitely have to know that. Institute people don't really think about lithium and amiodarone. They think beyond and they might ask this tyrosine kinase inhibitors. Number 3 are the cancer immunotherapy drugs. Drugs that are used in cancer immunotherapy in the current era. So these are checkpoint inhibitors, right? So what are the cancer immunotherapy? This has to go to 2018, where 2 scientists got Nobel Prize for the discovery in 1992 about these immune checkpoints. These are the things that negatively regulate the immune system. So there are 2 scientists. One is James P. Allison and second one is Takasu Honjo. These 2 got the Nobel Prize in 2018 for physiology of medicine for discovering this immune checkpoints, negative immune regulators, where there are certain compounds, certain molecules which can blind the immune system, which can negatively regulate or down-regulate the immune system. So these molecules are PD-1 and PD-L1, and then we have the CTLA4, cytotoxic T lymphocyte antigen number 4. We are going to discuss in detail later on in the subsequent sections whenever possible, but right now I'll just tell you these drugs can cause thyroid problems. Clear? So let me tell what are the things, how this helps in cancer immunotherapy. Remember PD1, PD-L1 and CTLA4, these are molecules that blind the immune system, which means they make the immune system to get down regulated. So the cancer cells use this because our immunity is comprised of not only of microbial immunity, we are also having cancer immunity. So what these cancer cells cleverly do is to blind the immunity, and to protect themselves, they secrete these ligands and they produce these molecules and they blind the immune system. We as humans understood this, and we are giving monoclonal antibodies to break this molecule, so that now the immunity wakes up and they understand that this is a cancer cell and they start destroying them, and that is helpful for cancer treatment. So what are the drugs? We have PD1 inhibitors. These PD1 inhibitors, there are two drugs. One is called a nivolumab and second one is pembrolizumab. And we have PD-L1 ligand inhibitors also. These are atezolizumab, and you have avelumab, and you have a durvalumab. And we have CTLA4 inhibitors also. Only one drug that is available right now, that is ipilimumab. I think some clever students must know where we studied ipilimumab. We have studied in lymphocytic hypophysitis in the pituitary section itself. So let us see how these drugs are going to cause thyroid issues. I'm going to put an image, show an image for you. This might help you understand. This is a graphical representation. So where this green tells you that this is anti-CTLA4, which means this is ipilimumab. And this yellow tells you that this is anti-PD1. In this example, I can tell it is nivolumab or pembrolizumab. And this gray tells you that this is anti-PD-L1 in this graph. So which means in this example, I can tell it is a durvalumab, or it could be avelumab or atezolizumab. Just I'm telling an example. This is a combination of drugs. Usually combination means we are giving a nivolumab and a ipilimumab. So this is a combination, ipilimumab and a nivolumab. So in all these graphs, you can see they can cause hypothyroidism, they can cause hyperthyroidism, they can cause lymphocytic hypophysitis, pituitary inflammation with lymphocyte infiltration. But in all these things, the combination is the maximum. So highest risk is always with combination. Fine. On the other hand, if you see hypothyroidism risk, this hypothyroidism risk is highest with, if you ask individual drug, that is with PD1 inhibitors only. That is nivolumab and pembrolizumab. Clear? Similarly, hyperthyroidism risk, if you ask individual drug, that is again more with PD1 inhibitors only, nivolumab and pembrolizumab. Obviously, combination is the maximum, but I'm also saying individual drugs. PD1 inhibitors are the ones that are maximally going to produce this hypo as well as hyperthyroidism. And finally, as far as hypophysitis is concerned, again combination is the key that's having the maximum risk, but ipilimumab as an individual drug causes high risk of hypophysitis. I think you can get it, right? And PD-L1 inhibitors, PD-L1, these are this atezolizumab, durvalumab and avelumab. All these are having lower risk of hyper as well as hypophysitis. In fact, hypophysitis, they don't have any risk at all with the PD-L1 inhibitors. So, but highest of hypophysitis is with ipilimumab only. So, these are some of the data that you have to know, but always combination is bad. Combination is having high risk of hyper as well as hypophysitis. Fine. So, these are some of the important drug-related causes that you have to know. And finally, number 4 cause, other cause of hypothyroidism that is upcoming is a new terminology called a consumptive hypothyroidism. Consumptive hypothyroidism. This is an upcoming and a very, very emerging concept, consumptive hypothyroidism. What do you mean by that? There are some large and bulky tumors. Large bulky tumors, especially if they are very bulky, very big. And what are the tumors? Like GIST, gastrointestinal stromal tumor, or some big hemangiomas, and certain hepatic vascular tumors. like HCC itself. So they do produce hypothyroidism. How? Because they secrete a lot of D3 dehydrogenase. They produce a lot of D3 dehydrogenase. We know what is the function of D3 dehydrogenase. They are going to produce reverse T3, which means they are going to inactivate this thyroxine and triiodothyronine. Thyroxine to reverse T3 and T3 to DIT, isn't it? So which means your T4 levels are going to drop drastically and inactive forms are going to increase, like reverse T3, right? So that is the reason why they produce hypothyroidism. That's why these cancers are using up this thyroxine. So that's why it's called a consumptive hypothyroidism. And you need a very, very high dose of levothyroxine to treat these patients. And once you treat the primary malignancy and you optimize the cancer, this hypothyroidism automatically resolves. So this is what we refer to as something called a consumptive hypothyroidism. It's a new entity. We have to know that. We are moving on to clinical features of hypothyroidism. Let us see a few clinical features of how adult hypothyroidism presents with. So we can divide into early clinical features, late clinical features, and those patients who are going to present with mixed edema crisis. Or we are also going to refer these patients as mixed edema coma. So what are the features of early hypothyroidism? Very non-specific, very vague, difficult to screen as well. Like weakness, lethargy and fatigue. They can have arthralgias and myalgias. You can see all these are non-specific. Headache, depression, cold intolerance, relatively very common. Cold intolerance, weight gain. But this weight gain has a very interesting, phenomenon. So whenever you get a weight gain with hypothyroidism, the patients will complain of weight gain despite poor appetite. I mean, which everyone hates it, isn't it? But similarly, in hyperthyroidism, you have an opposite thing. You will have a weight loss despite good appetite. Even though many people love it, but that's not a good thing to have. So weight gain despite poor appetite. Very, very important point again. They can develop constipation. Yes, very important one. And irregular menses. Please do remember your physiology textbooks will be mentioning as menorrhagia. But I believe it's irregular menses. Menorrhagia can happen, but irregular menses is the usual thing that we encounter in clinical practice, because remember, hypothyroidism also results in hyperlactin levels. One of the important causes of hyperlactin is primary hypothyroidism because of high TRH. So they might cause, amenorrhea and irregular menses. So that's why I told you irregular menses rather than menorrhagia. They can produce a PCOS-like picture, absolutely. You can get dry skin, xerosis. You can encounter hair changes like coarse and brittle hair and brittle nails, carpal tunnel syndrome. Remember, one of the commonest cause of carpal tunnel syndrome is severe hypothyroidism. But the most common cause is severe obesity itself can result in carpal tunnel syndrome. Apart from that, acromegaly, amyloidosis, many other causes are there for carpal tunnel syndrome. You can have a delayed deep tendon reflexes, especially slow relaxation phase. Slow relaxation. They contract okay, but the relaxation will be very slow. So this is what we refer to as a pseudo-myotonic reflex, or some books refer to this as hung up reflex. Don't get confused if you see this hung up reflex in the chorea. Chorea also produces similar kind of reflex. We call that as hung up reflex as well. So multiple names, or otherwise referred to as Voltman sign. All these relate to the same thing, that is delayed relaxation of the deep tendon reflexes. And they might have diastolic hypertension. Diastolic hypertension. Remember, hyperthyroidism produces systolic hypertension. Hypothyroidism produces diastolic hypertension. Clear? And they may have dyslipidemia, increased LDL with probably low HDL as well. This increased LDL, the reason is quite simple. We have studied this already. You have LDL receptors in the liver, and Thyroxine is one thing that constitutively stimulates the LDL receptors to be expressed in the surface of the liver, surface of the hepatocytes. So this is very crucial to take up the LDL molecules. And to ingest these LDL molecules and to take up these LDL molecules, these LDL receptors are very important. Hypothyroidism means you don't have sufficient number of LDL receptors, which means this uptake of LDL from the blood will be less, which means there will be lot of LDL that will be accumulating in the blood, resulting in excess LDL, and this might even predispose to high cardiovascular risk. So very important point. Okay, these are the early features of hypothyroidism. What are the late features? Late features include slow speech, and patient will be somnolent, very sleepy all the time, and hoarseness of voice. Madarosis, especially in the outer 1/3 of the eyebrows, this area. They lose the hair, but the mechanism is not clearly known. But this is referred to as something called a heratoxine. Very important for your practical exams. Heratoxine, otherwise referred to as a Queen Anne sign, because Queen Anne looks something like that in pictures. That's why Queen Anne sign. They might get myxedema. We all know the mechanism of myxedema. It is due to extremely high TSH. You will get only in primary hypothyroidism. Extremely high TSH. They can stimulate the TSH receptors that are present on the fibroblasts in the skin, which on stimulation by TSH may result in secretion of glycosaminoglycans, which might draw water, causing local edema. That's a pathophysiology, myxedema. Then you might result in periorbital puffiness, bradycardia, then effusions, pleural, pericardial, ascites. But one important point about this pericardial effusion is there. They can produce pericardial effusion and pleural effusion as well. But important point about this pericardial effusion is they never cause tamponade. They never ever cause tamponade by any means, because it's a slow pericardial effusion. The effusion accumulates over a long period of time, ml by ml, microliter by microliter, over a long period of time. So the pericardium has a lot of time to accommodate to that. They become more compliant and they slowly stretch and accommodate to this excess fluid around the heart. So the fluid goes outward, the force is outward towards the pericardium rather than compressing the heart. So they never develop a tamponade. But on the other hand, even accumulation of 20 ml of pericardial fluid acutely may result in a tamponade, because the pericardium here will not be compliant. So they cannot take up that much high fluid. So they will be non-compliant, resisting to this stretch, and all the fluid in acute situation will be compressing on the heart, resulting in a tamponade and death. Right? So never tamponade in the sense, there is, why I told you this point, because in 2015 NEET exam, one of the sessions, there was one very interesting question. They asked which of the following is not a feature of hypothyroidism. In that answer was pulsus paradoxus, because pulsus paradoxus is a feature of cardiac tamponade. Cardiac tamponade never happens in hypothyroidism, so pulsus paradoxus cannot happen in hypothyroidism as well. Fine. That's the idea. So they can result in atherosclerosis as well. We know that fact already. There is high risk, a lot of reasons why you develop atherosclerosis. And myxedema crisis. So what is the features of myxedema crisis? Everything will be hypos. Patient will be hypothermic. Patient will be hypoventilating with a lower respiratory rate, because it's an extreme form of hypothyroidism. And patient will be hypotensive. But please do understand this fact that in crisis they will be hypotensive only. But here I have mentioned it is diastolic hypertension. That's true. Yes, I'm not denying the fact. But remember, in crisis they will be hypotensive only. They will not be hypertensive. And they will be having hyponatremia. If you take the hyponatremia topic, there I would have mentioned that they produce a typical SADH-like picture, euvolemic and exactly SADH-like picture with a high urine osmolality and a low serum osmolality. You might not be able to differentiate this hyponatremia from SADH. Fine. They will have extreme bradycardia, like 40, 35. That will be the usual heart rate. And they will be hypoglycemic as well. And apart from that, they can have altered mental status. Altered mental status in the sense, usually they will be hypersomnolent. They will not get up at all. Hypersomnolent, or they can be in frank coma. They can even throw seizures. So anything can be possible, absolutely. So this is mixed edema crisis. You have to treat it very urgent basis. Almost 29% mortality according to the recent Japanese study in 2018. They told like 29% mortality, and other studies in US tells 50% mortality. 1 in 2 patients will die of mixed edema crisis if you don't identify, especially in the early stages. Clear? You have to treat disease with very high mortality. Clear? So usual precipitating feature and precipitating factor for mixed edema crisis will be a major cardiopulmonary illness or a neurological illness. A major cardiopulmonary or a neurological illness like infection will be the usual precipitating factor, even though certain studies tell severe cold exposure in certain temperate climates also can predispose to mixed edema crisis, but major cardiopulmonary illness or a neurological illness like infection is very common in India. Fine. So these are the features of mixed edema crisis. You have to treat on a urgent basis. Clear? So why you develop these features of hypothyroidism? I mean, you develop bradycardia because I told you one important fact that you have catecholamines, fine, and these catecholamines act on the catecholamine receptor, which are cell surface receptors, and they produce signal transduction. You can imagine noradrenaline in this case, signal transduction, and whether this signal should be transduced or not, whether this signal will be accepted or not, is dependent on intracellular cortisol. Clear? This is what we refer to as a permissive action of cortisol. This is what we refer to as permissive action of cortisol. Very important. If there is no cortisol inside the cell, this action will not be translated at all. Even though there is catecholamines, there will be no translation of the signal. Translation might go on, but ultimately signal will not be accepted. This cortisol permits the signal of catecholamines. That's why it is called a permissive action of cortisol. Cortisol is a very important hormone inside the cell. That's why cortisol is a hormone of stress. When catecholamines rise during stress, cortisol also has to rise because to translate this action, cortisol is important. But on the other hand, one important hormone is there that potentiates the action of catecholamines, which means they potentiate the signal transduction done by catecholamines. They don't permit. They don't have anything to do with permission, but they potentiate just. That is thyroxine. Thyroxine potentiate the catecholamine action. We studied this already in the physiology of thyroxine. This potentiation of catecholamine action is so important. That's the reason why in a hypothyroid patient you get features similar to that of low catecholamine, like bradycardia, hypothermia, hypotension, dry skin. Clear? In severe mixed edema crisis. At the same time, in hyperthyroidism, you get a lot of features like increased sweating, not dry skin. In fact, they'll have more sweating. They'll have tremors. They'll have tachycardia, atrial fibrillation. All these things are due to potentiation of this catecholamine action. Clear? So this is what we have to know about the clinical features. So, one more thing I missed it. So usually hypothyroidism in the long run, over a long run, they may result in myopathy as well. This is a late feature again. You can see myopathy also. Usually, as all the myopathies, it will be proximal. Very few myopathies are distal, like for example, a myotonic dystrophy type 1, but almost a whole lot of myopathies are usually proximal only. And these myopathies can produce severe weakness, especially in the proximal muscles, and they produce increased creatine phosphokinase. CPK might be elevated. At the same time, they might have pseudohypertrophy. One of the important causes of pseudohypertrophy of muscles is your thyroid hypothyroidism. You have seen that in cretinism also, certain features. You have seen that in adult hypothyroidism also, if it's extreme form of hypothyroidism. But even though in exam, pseudohypertrophy means it goes towards DMD and other muscular dystrophies only. But here, in adults, sometimes you can get with hypothyroidism also. So these are the features, and this kind of hypothyroid related myopathy is what we refer to as Hoffmann syndrome. This is called a classic Hoffmann syndrome, that is hypothyroid related myopathy. Clear? And finally, we are moving on to the treatment zone, management. How we are going to manage a hypothyroidism. Management of hypothyroidism as such depends on what is the category of hypothyroidism you are dealing with, whether you are dealing with a overt hypothyroidism, or you are dealing with a subclinical hypothyroidism, or you are dealing with a mixed edema crisis. Mixed edema crisis. Clear? So all these three treatments are different. Overt hypothyroidism, yes, all patients should be treated. All patients should be treated with replacement dose of levothyroxine. That's all. Overt hypothyroidism means you will have a low T4 with a high TSH. That's it. So you have to treat with replacement dose of levothyroxine. So you have to know the adult replacement dose of levothyroxine. What is the adult replacement dose? It is 1.6 microgram per kilogram per day. I have mentioned this dose in the congenital hypothyroidism itself. In congenital hypothyroidism, the replacement dose is almost 10 to 15 microgram per kilogram per day. But in adults, it's only 1.6 microgram per kilogram per day. Usual starting dose is 100 micrograms per day. Clear? That's the usual starting dose in Indian population at least, but you have to always calculate based on the weight. Fine. Is there any dose alterations needed? Yes. You can give a reduced dose of probably 0.3 to 0.5 microgram per kilogram per day, which means a dose of approximately 25 to 50 microgram per day starting dose in patients who are very elderly, age more than 65, or if a patient is having a cardiovascular disease, CAD. If they're having a cardiovascular disease or if the patient is having age more than 65, these patients will not tolerate high doses. Clear? Especially age more than 65 has a lot of other pitfalls also. You cannot, age more than 65, the TSH itself will be a little high. So the TSH may be very high so that you might be over-treating them. Physiologically itself, we have seen in the previous video that as age increases, TSH will increase physiologically. So you have to keep that in mind. So do not reduce the TSH aggressively like your younger patients. So give levothyroxine at a lower dose. You start with it, and how will you titrate? So do every 4 to 6 weeks once TFT. Every 4 to 6 weeks once you have to do the serum TSH. TSH is excellent for monitoring a primary hypothyroidism, no doubt about that. Every 4 to 6 weeks you monitor. So and you can adjust the dose by increasing or decreasing 12.5 to 25 microgram every time, depending on the TSH. TSH is still high, you can increase by 12.5 to 25. The TSH becomes very low, you reduce the dose by 12.5 to 25. Clear? Which means it's over treatment. So then after this 4 to 6 weeks, at one point of time, TSH will become stable. So once the TSH become stable, you can repeat after 6 months. You can repeat after 6 months. If still the TSH is normal after 6 months, if still you see a normal TSH after 6 months, in the sense, you need not do anything, just monitor annually after that. Annual TSH. Every year you can do a TSH. That's it. So this is how you monitor a patient with overt hypothyroidism. And the dose adjustment I mentioned already. And what is the goal, target? Target is normalization of the TSH. Normal TSH is the target. So normalization means whether it's high normal, low normal, or whether it is in the middle range. We have no consensus, no data. Just maintain a normal TSH. Even though there is some data to tell, the patient is very elderly, maintain in the high normal range. Because naturally itself TSH will be higher in the elderly. So you mimic that physiological response. So titrate the dose accordingly so that you maintain the high normal range. For example, if the lab value tells it's 0.5 to 5, you can maintain in the 4.5 to 5 range or 4 to 6 range. So you can maintain in the high normal range. Clear? So if it's a younger patient, less than 65 years, you can maintain in the mid-normal or low normal range. Low normal or mid-normal range. So maybe around 1.5, 2, that might be the correct cutoff. But please do remember, why we are keeping in the mid-normal or low normal range in younger patients is because of the fact that the mean TSH in general population is 1.4. So you want to mimic this 1.4. That is why in younger patients, we want to keep somewhere around 2, 2.5 like that. In older patients, we keep it in a high normal range. But please understand, there are multiple trials done on this, whether to keep in a low normal or mid normal or high normal. There is no consensus. Absolutely, there is no consensus. It's proven to be no benefit. It is just to mimic the physiology we are doing this. Apart from that, benefit-wise, there is no benefit proven by every single trial. The idea is to just keep the TSH in the target normal range, reference range. That's all. Low normal or high normal doesn't matter in benefit wise. To mimic the physiology, we split into older and younger and keep in the respective ranges. That's it. So is there any need for dose adjustment apart from the elderly patients? Yes. Where you might be needing lesser dose. Lesser dose might be needing in patients who are receiving glucocorticoids. Why? Because they will have a low TBG in those patients who are receiving glucocorticoids. Low TBG in the sense their binding capacity itself will be low. Giving a little dose of levothyroxine itself will saturate all the TBG and everything will go for free thyroxine only. So you need a lesser dose. It is easier to saturate the TBG if you have a low TBG. That's the reason. Where you want to have a higher dose. Higher dose is typically needed, first one, pregnant women, because in pregnancy, a lot of reasons, your TBG will expand and the amount of thyroid hormone needed to saturate those TBGs will be very high and the fetus will consume. At the same time, fetus will convert this T4 to reverse T3 because of D3 deadeness. So many reasons. You have to increase the dose. Typically, the dose increases by 30% at around 8 weeks mark. At around 8 weeks itself, 30% dose increments should be done. Either you can increase the daily dose by 30% or there are strategies where the obstetricians will tell in a week when you're taking 7 days of levothyroxine daily, you just take 2 extra doses. That's what they will do. So that is also one way of doing it, but generally it's better to increase 30% and according to the TSH cutoff. Remember the TSH cutoff in pregnancy is different. In a hypothyroid patient, 4 will be the upper limit of normal in the first trimester. Second trimester, it's equal to non-pregnant people. And if the patient is anti-TPO positive, you set up 2.5 as the cutoff, upper limit of normal, especially in the first trimester, to give levothyroxine dose. That's the cutoff. Below that only you have to maintain. So then, when you are initiating estrogen replacement, when the patient is being taken hormone replacement therapy, or if the patient is receiving tamoxifen, again it's due to high TBG, you might result in needing of a higher dose. Then third one, drugs that cause thyroxine catabolism, increase thyroxine catabolism. These are enzyme inducers. They cause more thyroxine catabolism like phenytoin, phenobarbital, rifampicin. We know these are enzyme inducers. That's the reason. Clear? And number 4, those conditions that reduce the GI absorption of thyroxine. It could be diseases like celiac disease or inflammatory bowel disease, or it could be certain drugs that you use that reduce the GI absorption, like proton pump inhibitors. We have some robust evidence on proton pump inhibitors also. Then with sucralfate, iron and calcium supplementation, very common. Like many patients who are elderly will receive iron and calcium simultaneously, especially women. So very important. You should not take along with them. So they might reduce the absorption of thyroxine. And cholesterol, obviously yes, we know this is supposed to reduce the absorption. Clear? So these are the agents that reduce the GI absorption of thyroxine. Some of the agents, many are there. So we have discussed about the dosages also, how to cause the dose adjustment in this population as well. So this is what you have to follow. And these are very important points. Whatever I told you are really, really important for exams. So now we have completed the overt hypothyroidism. What about this subclinical hypothyroidism? Subclinical hypothyroidism means you have a normal T4 but with an increased TSH, more than the reference range, more than the upper limit of normal. So that is subclinical. Whether you treat subclinical hypothyroidism or not, itself is controversial. Very, very controversial. How many ever guidelines you study, you will still end up in the confusion only, whether to treat or not. But one solid indication is there. Solid indication to treat a subclinical hypothyroidism is TSH more than 10. It is increased, but if it's more than 10, remember, more than 5 itself, I will call increased only. But if it's more than 10, definitely increased. So this is one solid indication, because many trials have proven that whenever the TSH is more than 10, the patient is supposed to suffer from increased cardiovascular mortality, dyslipidemias, and high risk of other mortality-related complications are there. So that is the reason why this TSH more than 10 can be treated. There is no doubt about that. But TSH is in the range of 5 to 10 is absolutely controversial. We really don't know whether to treat or not. But I'm going to tell the consensus what we generally use in general practice to treat these patients with TSH of 5 to 10. It depends on age, it depends on a lot of other features as well. So let me classify these patients under two categories. Those patients will have a TSH of 5 to 6.9 or 5.1 to 6.9, or those patients who have a TSH of 7 to 9.9. Remember, 5 to 6.9, you have to see what is the age of the patient. In both these situations, you have to see the age of the patient. Age is more than 65 to 70, or age is less than 65 years. Remember, those patients who are having age more than 65 to 70, this range of TSH, 5 to 6.9, could be just physiological. So no need to treat them. No treatment, just leave them. Because it could be just a physiological elevation of TSH. So you are confusing it as a hypothyroidism. So don't do anything, leave them. And less than 65 years, you have to see whether any convincing symptoms of hypothyroidism is there or not. Any convincing symptoms like severe fatigue, severe cold intolerance, severe constipation. Some convincing symptoms of hypothyroidism should be there. If not, again you don't treat. If yes, you're going to start the treatment. Clear? If yes means you have to start the treatment. Clear? Less than 65 years. If it is in the range of 7 to 9.9, 7 to 9.9, again see the age. If the age is more than 65 to 70, or if the age is less than 65. The age is less than 65, these patients can be treated according to a lot of trials and studies. If it is 65 to 70, more than 65 to 70, older age people, again you have to see whether is there any convincing symptoms. Then only you can start the treatment. Clear? So this is how you are going to approach a patient with subclinical hypothyroidism. But more than 10, definitely yes, you will be treating with standard dose of levothyroxine. So again, the dosage is problematic here. So what many guidelines are telling is you can give a standard replacement dose of 1.6 microgram per kilogram per day. If it's a patient who's having, whose age is less than 65 years and have no CAD. Similarly, if the patient is having age more than 65, or if the patient is suffering from a coronary artery disease, some cardiovascular disease, then you have to reduce the dose to again 0.3 to 0.5 microgram per kilogram per day, which means you will start with only 25 to 50 microgram per day. There are even certain consensus that are telling this is a wrong dose and you have to start with 1.2 microgram per kilogram per day. This is the dose of subclinical hypothyroidism. But tremendous confusions are there. But only one thing I would tell, go for only one concrete answer in exam. This is the only thing that has a reasonably good evidence for treating a subclinical hypothyroidism, that is TSH of more than 10. And that also become a problem now, because one recent trial has told that if the patient is old age, in any GM it is still there. If the TSH is 5.1 to 19.99, especially if the patient is old, more than 65 years, there is no benefit from treating with levothyroxine, even if it is more than 10. So they're telling no benefit. So which to follow? Honestly, no idea. Clear? So this is a very, very controversial zone. So no need to go about that. So in exam, answer the single most solid indication for treating a subclinical hypothyroidism in any age group is TSH of more than 10. That's what you have to think in exam. That's all, only one point. Fine. If you want, like if somebody asks you for a practice, you can use this algorithm which I have given. And again, it depends on a lot of personal expertise and personal practice. You see whether that patient needs thyroid hormone or not. Otherwise, don't give if they don't want. Clear? Then how you're going to go about a myxedema crisis? This is an emergency, right? Myxedema crisis is an emergency. A lot of guidelines tell use both T3 and T4 together. But I believe, immediately you have to start with the T4. Whatever form of T4, you have to start with the levothyroxine. But the guidelines tell you have to start with the intravenous thyroxine, IV T4, at a dose of 5 to 8 microgram per kilogram immediately, as soon as possible. Usual standard dose, what we prefer in our general practice is 200 to 400 micrograms. Immediate dose, IV. But suppose, remember, this is for Indian practice. If your IV is not available, which is the case in most of the scenarios, your nasogastric T4 is as effective as your IV T4. So because patient will be in coma, put a nasogastric tube and start the thyroxine. At least the crushed thyroxine you can give through the nasogastric tube. That's very important. Don't wait for the IVT4 to be available. But the guidelines still you have to start with IVT4. And once you have given this loading dose, this is a loading dose that we are talking about. So once you have given this loading dose, after this you can go for the maintenance dose. Maintenance dosing. So remember, if you are using IV, the maintenance dose should be at least like 25% to 30% lesser than what you give for the oral dose, because the bioavailability is better with IV. So we usually give a 50 to 100 microgram IV OD. So this is the maintenance dose we give. But remember, if you are using an oral dose, you can use a solid 1.6 microgram per kilogram per day. That's what the oral dose is all about. But if you're giving an IV, means this is the dose you have to follow. You have to reduce by 25 to 30%, because otherwise it will be too much. A lot of guidelines tell you can optionally add a IV T3 also. This is an optional thing, plus or minus IV T3, if at all you're having some hemodynamic instability. If at all you're having hemodynamic instability, clear? Or if you're having severe bradycardia, or if you're having severe hypothermia, in these conditions, optionally you can add an IV T3 also. What is the dose of IV T3? We will be giving 5 to 10 microgram IV every 8th hourly. Clear? 5 to 10 milligram 8th hourly will be giving this IV T3. But remember, T3 is more arrhythmogenic than T4. So you have to be very cautious in giving T3, especially in older patients. This might cause atrial fibrillation and arrhythmia. Because thyroxine hormone, why we worry in elderly is because of two reasons. One, they produce AF. High risk of AF is there if you slightly give increased dose of thyroxine. Second, bone problem. So when you give chronically high dose of thyroxine, they may go for osteoporosis, because hyperthyroidism is associated with hypercalcemia as well as osteoporosis, because they can stimulate the osteoclast through beta-adrenergic receptor pathway. So that's the reason why we worry to give a higher doses in older patients. Fine. But whatever you do, when a patient is having a mixed edema, do not forget to add a empirical hydrocortisone. You have to definitely give an empirical steroid. Empirical hydrocortisone is mandatory. Why? The reason is very simple. If the patient is ending up with a mixed edema crisis, such as severe hypothyroidism, there's a lot of chance, but the patient may be having associated other autoimmune manifestations like Addison disease also. So suppose if the patient is having Addisonian crisis, in Addisonian crisis, usually end up with a tachycardia, fever and all. But remember, this hypothyroidism can mask the Addisonian crisis. Patient might be having underlying Addisonian crisis, but this hypothyroidism can mask it. Because why you get tachycardia? Because of catecholaminergic stimulation. If there is no thyroxine, the catecholaminergic stimulation of the heart will be very poor. So if the patient is having fever, if the patient is having infection, if the patient is having underlying Addison crisis, presence of severe hypothyroidism and mixed edema can mask all these features. They may not have tachycardia, they may not have fever itself. Clear? So that is the reason, till you concretely rule out an underlying adrenal insufficiency, give empirical hydrocortisone. The usual dose is approximately 100 milligram IV TDS, 8th hourly. At least for 2 days you have to give, followed by tapering doses. But remember, in those 2 days, it's believed that you have to rule out adrenal insufficiency. You have to take serum cortisol, you have to do a ACTH stimulation test, something you have to do, and you have to rule out your adrenal insufficiency, then only you have to stop the hydrocortisone. But in the presence of adrenal insufficiency, if you are going to give T4, the patient will go for severe adrenal crisis and they will die. So don't do that. So till you rule out, give empirical hydrocortisone, no harm. And infection is there means you give antibiotics. That only is a general protocol. So we are not going to interfere in all these things. So nutshell, what's the treatment? Finally, IV T4, or you can use a nasogastric T4 plus empirical steroids is mandatory. Empirical glucocorticoid in the form of hydrocortisone is mandatory. Definitely, this is definitely should be given. Plus or minus IV T3. This is optional if you are having unstable patients. So this is the treatment for mixed edema crisis. This is what we're going to use. I'll finish with an interesting case story. So I was working as a first year PG resident where I had a case with a sodium of just 117 milliequivalents per liter. And the patient came with coma, and the patient came with seizures as well. And I did all the workup. Initially, I gave a 3% NaCl bolus. The seizure seizure has responded. Seizure is no longer there after giving a 3% NaCl bolus as per the protocol. But the patient is persistently comatose. I couldn't understand why. Then I saw the heart rate, it was only 43 per minute. But I was thinking that this hyponatremia must cause a raised ICP. This raised ICP could have activated the Cushing's reflex, and probably that is the reason patient is quite bradycardic. So I was waiting and I was pushing on more and more, 3% NaCl. But within the range, don't worry. Within the correction range, I didn't exceed the correction limit, but still I was pushing more and more 3% NaCl, and I was trying to correct more and more this hyponatremia. The patient never responded. Patient was comatose. So I don't know what to do. Then I called my chief, because I always believe in calling my seniors and ask. So I called my chief. I asked, so what to do? My chief asked all the case details, all the history, and he saw the ECG also. I sent through WhatsApp. So finally he told, do a TFT. Looks like she is mixed edematous. So then we did TFT. The TSH report came. It is more than 150. Boom, it's a mixed edema. This hyponatremia can happen in mixed edema, especially in crisis, which can mimic SADH. Actually, I was very convinced with SADH because this patient had a higher urine osmolality with a high urinary sodium and a low serum osmolality. I was absolutely convinced that this patient is having a SADH only. Coupled with that, this patient had a pneumonia in the chest X-ray. She had a little bit of consolidation in the right lower lobe. So I was pretty much confused because pneumonia is an important cause of SADH. I was very, very convinced that this patient is having SADH, and I started treating like SADH. And my chief told to do the TFT, and I did TFT. TSH is more than 150. You don't believe. We gave an IV T4. In 10 minutes, patient woke up. Just in 10 minutes, patient woke up. And patient was intubated and she was trying to pull the tube out. So that's the power of experience, number one. At the same time, once you do mistakes, you realize that you don't do it again. You don't repeat it again. So hypothyroidism is such a common case, and you have to be very clear. From your conscience, you have to treat. Subclinical, yes, controversial. Overt, you have good guidelines. Mixed edema, you have a good guidelines as well. So treat carefully and save the patients. That's what we are there for. And cheers. And we go to the next topic, hypothyroidism.